All right, well, good afternoon. We appreciate everyone joining us today, and we're very excited to have Mr. Charles James with us. He'll present his expert knowledge on the evaluation of management and billing for FQHCs. This webinar is being recorded and added to the UMTRC resources page for all of our members around the state. Just a few quick housekeeping items before we begin. As I mentioned, we're recording today's session and it will be available on the UMTRC's YouTube channel within about a week once the recording is processed. If at any point during the presentation you want to ask a question, please use the Q&A function. This function is accessible by hovering your mouse over the screen. It should pop up either at the top or bottom of your screen, depending on what view mode you're in. The UMTR staff will keep an eye out for those questions and will moderate for the presenter. We will now turn it over to Mr. Charles James for his presentation.
Thank you very much, Carolyn. It's good to be here as always. Thank you to Indiana Rural Health Association and Upper Midwest Telehealth Resource Center, if I got that correct, for getting us all together today. This is the third in our series of FQHC billing webinars. Today, we're going to focus on evaluation and management services. As with all things FQHC and or RHC, we're already in the advanced class, right? So there's no way to cover evaluation and management properly, in my view, for FQHC without laying some groundwork. So we've got quite a bit of material today. I'm sure I'll go over just a little bit. A few of these slides I'm going to have to just really kind of give short service to and rely on you all to do some self-study on the details of some of these slides. But the point is that we want to look at how to report claims for FQHC evaluation and management services. So I actually abbreviated this quite a bit for today's presentation and cut out a lot of some of the things that we will assume we already know and some of the core FQHC principles so that we can focus on some claim examples. Some of this will be duplicative of what we did in our care management session, but that's an important enough service that I don't mind revisiting that. And as we get to the care management services, I talk to a lot of providers across the country on a weekly basis, and many are still suffering from low volume. Many are concerned about the services that they can provide virtually, and these care management services offer a wonderful opportunity to generate some revenue. I hate to put it that way, but we need to generate revenue. They offer an opportunity to treat patients and be able to be paid for treating patients when we don't necessarily have consistent face-to-face visits. So what I want to really emphasize is these care management services, I think, are a big opportunity to supplement what we're doing in this pandemic and treat patients, because we know our chronic patients need to be seen. So let's dig in. These are, well, we don't have more than one section today, so I meant to take the section one out, but these are the areas we're going to talk about. We all know who we are and why we're here. We're FQHCs. We were established in 1990. Part of the reason that there's a big differential in FQHC reimbursement with RHC reimbursement is because FQHC reimbursement was created later. So we have all of the same guidance, but the statutory source of FQHCs, created an immediate difference with them relative to reimbursement. Well, we're here to learn about E&M billing today, but know that that's part of where we part ways as RHC and FQHC, even though we share all the same guidance in a lot of ways. We're safety net providers, and we're providing services typically furnished in an outpatient clinic. So the intent of the legislation is that we are primarily primary care services, even though the language in the Medicare guidance says services typically furnished in an outpatient clinic. Okay, we can quibble with these words. We all know why we're here and who we are. We're paid on a PPS system. Many of us may have been paying attention to the recent change in RHC reimbursement. RHC remains an all-inclusive rate, which means we file a cost report and our rate can fluctuate annually. PPS is really kind of a set it and forget it. It's oversimplification, but we're issued a rate. We get effectively MEI increases every year, but our cost report does not increase or reduce the rate that we get. We're PPS, it's set, it stays, we're PPS. It's a big difference, and I encourage you to look at some of those differences on your own. Medicare Benefit Policy Manual, Chapter 13, Medicare Claims Processing Manual, Chapter 9. Those are our Bibles for everything that we do as RHC FQHC. All of the same guidance applies to both of us, but once we start applying our RHC and FQHC guidance to claims, again, claims out, we differ dramatically. But no, I don't like to recreate language. So almost everything I have, my claim examples with the exception, is Medicare language. Face-to-face medical or behavioral health visit, or a qualified preventive visit. We have to have a face-to-face encounter between a patient and one of our providers where we're rendering FQHC services in order to have a billable encounter. Transitional care management also constitutes an FQHC visit. Now, we have to put a huge asterisk on this as for FQHCs because we've got our G-Payment codes that we apply fees to. But largely, we're not going to affect our fee schedule because we're FQHCs. Conversely, because of our status as FQHCs, it does not eliminate the urgent necessity to maintain our fee schedules just like any other healthcare operation would. We looked at in our initial session about how we set fees, and we're going to see momentarily why it's really important that FQHC fees keep up with, are maintained appropriately, because if we don't keep our fees, we're never going to get our PPS rate. We're going to see why that is momentarily, but we don't have a separate fee schedule because we have a lot of self-pay. We don't offer a different fee schedule. We apply discounts to our sliding fee scale, but in general, our fees stay the same. We don't have a special fee schedule because we're an FQHC. We've already established some of our providers: physicians, nurse practitioners, PAs, certified nurse midwives, clinical psychologists, LCSW, CSW. And for FQHC, a dramatic difference for us is that we get diabetic self-management training and medical nutrition therapy as an encounter where RHCs do not. So that is a qualified encounter for FQHC where it is not for RHC. We know that we have to deal with medical necessity. I probably have some of my slides a little bit out of order here because don't tell anyone I may have been manipulating these right up to the last minute, but that's okay. So these are not medically necessary encounters. If we're administering an injection, that's not an encounter. We're doing a dressing change, that's not an encounter. Lab result or test, that's not an encounter. Now, here's what I will tell you. Writing and refilling scripts, not an encounter. Nurse visit, not an encounter. Lab test, if you have an encounter that your chief complaint is lab test, I offer you that we need some documentation brush up, because we should never have a chief complaint or a reason for a visit as a lab result. It should be follow up for whatever condition we're testing for. So my position is a lot of these medical necessity are documentation problems, but know that just an injection, certainly B12 or allergy, those are not encounters. And so we would have to bundle those with an otherwise medically necessary visit. 99211s are not encounters for us. We have some wiggle room on what we can do on telehealth, but I really don't want to cloud the conversation here. We just need to assume, and especially face-to-face visits in the center, Nursing visits are not encounters. Now, when I get to a good place, I'll point out some language to you. I won't do it quite here yet. Just like RHCs, we share a common definition of our FQHC services. Physician services, service supplies incident 2. Service supplies incident 2 are nurse practitioner. Services of NP/PA, certified nurse midwife. Service supplies incident to them. These are all FQHC services, not necessarily encounters. Visiting nurse services to the homebound. Pandemic trivia. Right now, any health professional shortage area is a home health shortage area during the pandemic only, so that we don't have to rely on home health shortage areas to be able to provide visiting nurse services. I know of no one ever who I've ever talked to that take advantage of the visiting nurse service. Doesn't mean they're not out there, but I think they're probably pretty limited. But I think that's a benefit that we should look more closely at, because that allows RNs to go to the home and charge an encounter. We're not going to focus on that today. Clinical psychologists, LCSWs, for us, registered dietitian, medical nutrition therapy, these are FQHC services. And then, just for the record, otherwise covered drugs furnished incident to the services of our providers during an FQHC visit. I paraphrase a little bit, but we are not able to separate our injectable medications from our encounter and bill them separately. Of course, as FQHCs, this is one departure from RHC. We have certain primary health services that we, by statute, which means by law, have to be able to provide that Medicare doesn't cover a lot of these. So these services are what we would offer to our pregnant mothers. Or cancer screening, some of those are, of course, covered, but well child, immunizations, preventable disease screenings, et cetera, pediatric services. None of these are covered Medicare benefits. It means we can't submit a claim for them, but your requirement as an FQHC is that you have to be able to provide these. So it's just like our lab services. Just because we have to be able to provide a basic set of lab services does not mean those are covered as FQHC services. The same in the RHC. As RHCs, we have 6 basic lab tests we have to provide, but that does not mean we bill those as RHC services. I'm looking for my keyboard controls here, pardon me. Preventive encounters. These are, of course, covered visits, are welcome to Medicare, annual wellness, subsequent annual wellness visit, and the rest of our Medicare screenings that have been approved by the US PSTCF, US Preventive Screening Task Force, which that's how we get our different gradients of preventive services by how the USPSTCF grades these. So those are covered encounters. And I think I have a duplicate slide. Oh, no, these are the Medicare preventive screenings that are covered as encounters. When they're provided individually, each of these would be an individual encounter. When any of these are provided in conjunction with any other type of visit, they're what are called standalone encounters. When these are by themselves, they're encounters. When provided in conjunction with any other encounter, we don't get a separate payment. We just get one encounter payment. But any of these are standalone encounters. They can be billed by themselves. So if, and I don't have an explicit slide on this, so let's say we're providing a let's do a cancer screening. We're doing a cancer screening, but it's going to go on our claim. We already have, let's say, a welcome to Medicare visit or an annual wellness visit. We have the cancer screening that's going to go on our claim. Why would we report the cancer screening if it's not going to affect our reimbursement? Well, especially as FQHCs, you're in the quality reporting business, right? So you're going to have measures that you're going to be assessed on. And so we really need to report all services as they're rendered, even if they don't result in separate reimbursement. So it's important to report all of these, even if they don't result in additional payment. We also know that flu and pneumo are not paid on our claims. Those are paid on the cost report, even though as FQHCs, excuse me, we do report those on our claims. If there's an encounter to report them for, we're going to cover that. So let's talk about Incident 2 services. These are, of course, the services, service and supplies, Incident 2, physician, nurse practitioner, etc. They're commonly rendered in the office. They're, when I say under physician's direct supervision, whoever we're billing the claim. So if we're billing a nurse practitioner under a physician direct supervision, means the physician is in the clinic. So we have direct supervision for all Incident 2 services furnished by a staff member, not a contract, drugs and biologicals, et cetera, et cetera. I think we know what most of these are. They're limited to situations where direct supervision of the person performing the service, which means the physician or billing provider, in this case, if it's a nurse practitioner and we're billing Incident 2 a nurse practitioner, the nurse practitioner must be in the clinic, not necessarily in the exam room with the person providing the Incident 2 service. Direct supervision means the billing provider is in the clinic, not necessarily in the same exam room. So if we bill a nurse practitioner PA claim under their supervising physician, that's an Incident 2 claim. We don't like to do that. We get 100% reimbursement of our nurse practitioner PA claims in an FQHC, so we don't have any real good reason to bill under a supervising physician because we're really just limiting ourselves to direct supervision. And let's face it, if we're billing a nurse practitioner and a physician, we're saying that physician is always in the clinic when the nurse practitioner is reporting claims, and we know that's not the case. So we're really opening ourselves up to some compliance risk here. We're paid at 100% of our fee schedule for Medicare and Medicaid, so there's no good reason to bill. Yes, on a commercial, you're going to take a 15% hit on many of the commercial plans. Call that economic opportunity for not creating yourself compliance risk. So you're going to have different requirements for different plans. Follow those plans. And we're way past the days of just billing nurse practitioners and PAs under their docs. I would suggest discontinuing that. Incident 2 services, we've already seen some of these as not medically necessary. So injection, suture removal, none of these would be medically necessary encounters and would all be part of an otherwise payable encounter. We know that now we start talking about payments, we have reporting our charges and we have calculating our payment. So for our PPS FQHC services, we have adjustment factors. We have two different, really three, but two of them are the same. We have a geographic adjustment factor. So our PPS is going to be multiplied by a geographic adjustment factor based on our locality. So most of our FQHCs in rural areas will have a geographic adjustment factor under 1. Our FQHCs that are urban or suburban areas will have a geographic adjustment factor, generally speaking, of greater than 1. We have a new patient adjustment and a welcome to Medicare or annual wellness visit adjustment of 1.3416. So effectively, we're going to multiply our PPS by 1.34 for those types of services. We're going to take a look at how this works. The dramatic departure for us for billing, evaluation, and management services as an FQHC are with our payment codes that we apply. So the payment codes came out with what? The final PPS mechanism. I think I'd have to go back and look at my guidance, but we haven't been this way forever. I think it was 2015, but don't quote me on that, when we moved to the G payment code. So in effect, all of our new patients, our clinical visits for new patients, we're going to tack a G0466 on the top. All of our established patients, clinical visits, get a G0467 on top. Same with G0468, all of our preventive visits. G0469, behavioral health new patients. G0470, we're going to look at how these get billed. We have a qualifying visit list as FQHCs. It differs slightly from our RHC counterpart, so be sure and pay attention to that. We just break things apart a little differently is the biggest thing, because we have these G-payment codes. So our qualifying visit list really says, okay, here's a G-payment code. What qualifies under that G-payment code? So our new patients, we get all of our new patient visits, and we also get, look over here on the right-hand column, all of those screenings that would certainly apply to new patients. So new patient E&Ms, as well as our Medicare preventive screenings. Here's our qualifying visit list for an established patient. Same with our preventive visits. These are preventive qualifying visit codes for G0468, G0468, and then G0469 for our behavioral health, etc. You all can also look at those. I'm just regurgitating the qualifying visit list here. But look at our behavioral health. So they're the same for our new patients and our established patients. And I always have folks wanting to throw in like a meet and greet. I'm not sure what the HCPC code is. There's like a meet, say hello. It's not an initial assessment. It's a, hey, here, behavioral health services are available to you. That's not an encounter. So these are very strictly for Medicare, the qualifying visit codes that go with those. So for the preventive services and more detailed explanations of all of those, please see these links. Our MedLearn Matters 9234 for our care management. Now, note that's going to be a little bit out of date at this point, but that gives us our initial guidance for that. So back to the fee schedule, we're going to charge everybody the same way. We're going to have the same charges we do for our Medicare beneficiaries as we do for our Medicaid beneficiaries as we do for our commercial. We may waive collection of all or part of our co-payment depending on the beneficiary's ability to pay. That's part of our FQHC status, because we are required as FQHCs, of course, to see all patients regardless of ability to pay. Because FQHCs, we are automatically loan repayment sites by HRSA. So where RHCs don't have some of these requirements because they're not automatic loan repayment sites, they have to apply for that. FQHCs are, so we have to have a sliding fee scale. And so we may waive part, all or part of the co-payment depending on the beneficiary's ability to pay, i.e. your sliding fee scale reporting mechanism. So we can't do that. We have to bill our claim detail on our FQHC claims with our G codes. So the costs associated with those, let's see, sometimes I get my language, I have to refresh my memory here, but provided RHC not reflected on the service line, but submitted on the billable visit, blah, blah, blah. You know what? Let's just take a look and see what it means on the claim. So service level information, basically we have to provide the detail for the services that we're rendering, be they clinical, behavioral health, diabetic self-management therapy or training, and our behavioral health visits. We're going to use these various revenue codes to report our services. So 0521 is for our center, 0522. So one thing I was going to say in the guidance, when you look, and this actually is probably misstated, when you look at the Medicare Benefit Policy Manual, and the language says center, a clinic or center, a clinic is referring to an RHC. A center is referring to FQHC. So sometimes the guidance can get a little confusing, but just know, because it seems to conflate those words, which it does, because a lot of the same things apply to us, but where we want to look at Medicare Benefit Policy Manual, we're going to refer to ourselves as center. So I misstate that 521 a little bit. So our visits can occur at the clinic or center, the patient's home, a Part A SNF. So these correspond with our locations. Venipuncture, we're going to report on our claim as a 300. All of our injections and immunizations are going to be 636. 780 telehealth, that's really for originating site services. So we don't want to use that right now. And behavioral health of 0900. So let's take a look at some claim examples. Global billing, basically we don't have a global period. Today is our global billing period. In the center, this is a perfect example here. This is directly out of Medicare Benefit Policy Manual. The center is paid based on PPS rates and not subject to Medicare global billing requirements. If we have a surgeon, for example, a lot of our centers are integrating specialists, and we encourage that to happen. But let's say we have a surgeon in our center and they do a surgery at the hospital. The surgery at the hospital, the global billing period for that will follow us back to the FQHC. So if it happened in the hospital, we have a global billing period at the FQHC. If it happened at the center, today's the global billing period. So minor surgical procedures are absolutely encounters that would be under an established or new patient G code. And of course, follow-up visits for dressing changes and suture removals are not encounters. They're only encounters if there's some medically necessary reason that it would be. Office visits and surgical procedures, these are one encounters. We don't have two separate encounters. Injections and surgical procedures, we still have one encounter. We cannot pull injections out and bill them fee for service on a 1500. That is commingling. Commingling is when we're mixing payments and we're peeling Medicare Part B fee for service claims off when they should be included under our FQHC benefit. Don't do that. That's duplicate reimbursement. And that is the same as financial triage, which is selectively choosing higher or lower reimbursement rates for that service. I'm speeding through some of this, as you can tell. Hospice is not included in our FQHC benefit. There's actually just been a change on this with RHC Modernization Act, so I need to look at that. It definitely changed hospice a little bit. But for right now, we're going to go with our old guidance that hospice is report. We can treat non-hospice related services by entering a 07 in our condition code and non-hospice in the remarks. If our center, and I think this is the change now, if our center treats a hospice patient for their hospice condition, I believe we can now get paid for that. But don't quote me on that. I need to do some homework. Non-covered services, we can offer a 710 type of bill to prompt a rejection that we can send to a secondary payer. So that's how we would handle a non-covered service. A good example would be, let's say, a PAP that patient has a secondary benefit that will pay an annual PAP, but Medicare only pays biennial. So we submit a non-covered charge to get the rejection so the patient could send that on to their insurance. We have two different visiting specialist scenarios. Number one, they come in, rent their space, they do their own billing. We carve them out. They never touch us. We remove all their costs from our cost report. We put a sign that says, hey, the specialist coming in, they're not part of our center. They're going to do their own billing, expect a different EOB, versus just have the surgeon as part of your FQHC and bill encounters for that surgeon. Any specialist that's doing primarily evaluation and management in our FQHC works just fine. So think cardiology, ENT, general surgery, of course, pediatrics, that's not specialty care. So oncologists, orthopods, the word was escaping. Look closely at those, but anything that's heavily E&M in the clinic, have at it. These are our behavioral health providers. We talked about this at length in our behavioral health billing, so I'm going to kind of speed through those. We have to have our G code bundle of services that we apply to all of our G codes. Payment is made for us. Now we're finally getting to how to bill and report our evaluation and management services. So payment for our G code is made by comparing the adjusted, means we've applied the geographic adjustment, we've applied the new patient or behavioral health adjustment, the adjusted PPS rate, to the submitted covered charge for our G-payment code. We have a static G-code charge amount. Our service detail is going to fluctuate along with how many services or how few services we provide, but we're going to have a static G-payment code that is based on the normal complement of services. So when we started to do the G-payment code, everybody should have gone out and looked, what is our normal complement of services for an established patient? What is our normal complement of services for a new patient? And that's what gets applied to the G code. So let's say the normal complement of services for an established patient would be a 99213 and an injection and administration. That total is what we put on the G payment code. So the G code charges that we used in this presentation are based on the total charge for the services rendered in the example, just to kind of keep it straight. But just know your G payment code charge amount is going to be fairly static, but the detail that you report with those is of course going to fluctuate based on the services rendered. Here are the steps in how to calculate a payment. This came directly out of the claim processing manual. First, we're going to determine the lesser of the provider's submitted charges and the fully adjusted PPS rate. Keep that in mind. We're going to determine whether or not preventive services have been covered or provided. And then we're going to determine the lesser of our our charge for the payment code, not our service detail, but for the payment code, or our adjusted PPS rate. We're going to use the lesser of our adjusted PPS rate or our G code charge amount. We're going to take the total from step 3 and multiply by 80%, and that gives us our Medicare payment. So let's take a look. Well, I keep saying that, and I have more slides. I swear we're going to take a look here momentarily. To calculate the co-insurance, we're going to determine the lesser of the charges or the PPS rate, go through the same calculation, determine whether or not they're preventive services. We're going to subtract preventive services from the lesser of our charge on the G code or the PPS rate. And if there are no preventive services there, we're going to multiply that same step 3 total, this one, by 20% instead of 80%. And that will give us our co-insurance. Hey, yay, we finally have one. Let's take a look. I'm not going to go through each of these individually. But no, we've got ample material for study here. So this is a new patient. We decided that our new patient complement of services is typically $195, and that's probably a 99204. Yeah, it is. Look at that, 99204 with a routine venipuncture. We decided is our normal complement of services, and lo and behold, it's exactly what we provided for this particular patient. So this is what the claim detail would look like. We have our G payment code plus our claim detail. As with RHCs, our 001 amount is inaccurate, inflated, not right. And yes, you have extra revenue in that that's going to go on your PM, your practice management system, but that's going to adjudicate out when this claim pays. So yes, because of this PPS reporting system or G code reporting system, we have inflated revenue because of how we have to report these charges. We're duplicating our charge amount, basically. But again, that's going to adjudicate out when this pays. So let's take a look at how to fully adjust that PPS rate. So first of all, our base rate for this particular center, was $158.85. I went out, I looked up the geographic adjustment rate for our clinic, and our geographic adjustment rate for our zip code is 1.059. So we're going to take our base rate and multiply that by 158.85 and multiply that by our geographic adjustment. It's unique to us. So what does that geographic adjustment multiplier tell us about this location? This location is actually in an urban or suburban area because that geographic adjustment factor is greater than 1. we're going to take our adjusted PPS rate and we're going to multiply the new patient multiplier of 1.3416 to our adjusted PPS rate. We're going to get a fully adjusted PPS rate. So we've adjusted for the geographic location and for the service being a new patient. So we get a 1.34 benefit for being a new patient. So our fully adjusted PPS rate is 225.68. So we've done two adjustment multipliers to that. Our G code, let's come back to here, is 195, which is less than, so I'm gonna look back here. Our G code's 195. Come back to the charge amount. 195 is less than our fully adjusted PPS rate. So Medicare is going to pay 80% of our charge amount, 80% of 195. The patient's going to pay 20% of 195. So magically we get our charge amount out of that. That's how we report the service. Let's take a look at an established patient. An established patient, our G-Payment code, our normal complement of services is $150. Hopefully this gets what? Reviewed annually, along with our fee schedule is reviewed annually, right? But in this case, we did not have our routine complement of services because we just provided an E&M code. But even so, our service detail is 135. We still report our G-Payment code of 150. Like I said, that's static. The service detail fluctuates. Our payment calculation is based on, I can't tell you how many times I went through this presentation and aligned my numbers so that they wouldn't be out of line like that. But I digress. Our G-Payment code is 150. That is less, so we only have one. We only have our geographic adjustment. We don't have a new patient or a welcome to Medicare adjustment. We just have 1.059 as our geographic adjustment. So our adjusted PPS rate is 168.22. Our G code 150 is less than our adjusted PPS rate. So again, Medicare is going to effectively pay us 80% of our charge amount. G-code charge amount, and the patient's going to pay 20%. Now, a couple things that we're going to look at here. And first of all, in effect, we're getting 100% of our charges out of this, right? So even though we don't get our PPS rate much of the time, 100% of our charges isn't a horrible deal. Now, remember what we talked about in our fee schedule setting. And our provider enrollment and fee schedule. This is why it is essential to maintain your fee schedule annually. Because if your fee schedule hasn't been maintained, we had been pushing our clients for 2 years prior to the PPS rate to get your charges up. As FQHCs, we want to undercharge. I get the compulsion, but it's the wrong way to do it. Have a full fee schedule, but use discounts so that if we have an artificially low fee schedule, we're never going to get our PPS rate out of it, are we? This is why we have to maintain our fee schedule, because of course, it sounds stupid to say it has a direct impact on our reimbursement, right? But we can see that, of course, while that's elementary, how much we charge has an impact on our reimbursement. Since we have these complicated payment calculations, it really, has a magnified effect, let's say. So here's another office visit. I'm not going to be able to go through each of these. I'll invite you to, especially the payment calculations. So in effect, this one's still going to be under our PPS payment. We can see now we've just added the detail, and now our service detail is going to exceed our G-Payment code, but our payment's still based on the 150 on the G-Payment code. Welcome to Medicare. Medicare is going to pay us 100% of the lesser of our G-Payment code or our PPS rate, and there is not any beneficiary co-insurance involved. A lot of people ask about the PS modifier on here. I think a lot of people don't end up using it, but it's in the claim processing manual, so I couldn't leave it off. I don't really think it affects your claims. They go by the G code or the HCPC code. We can see our welcome to Medicare visit here, and our G code's less than our PPS payment. So we're going to get $165, 100% of our charge out of that. You know, we'll take it, right? New patient visit. Oh, I didn't update my date, but again, this happens to correspond with our normal complement of services for a new psychiatric evaluation. And so here's what that payment is going to look like. We notice the trend on none of these have we've been able to get our PPS rate out of it. Established patient for behavioral health. Here's what that claim would look like. Pardon me for my dates being a little obsolete. But then once again, now here's where we have, let's see, our, I think I have a mistake on that. Our charge amount is $320. This is why this is a difficult presentation, right? Oh, I see. So our established behavioral health is $320 because normally we do 30 minutes of counseling or treatment and pharmacological management. So we have a G payment code of $320 on this. So on this instance, we do get our PPS rate out of it, and our co-insurance is going to be based on the $320. So, you know, a lot of study for you all to go down plenty of rabbit holes on these. This is how we'd report our flu shots. We do not report a claim for our flu shots if we have flu shot only. We only report the flu shot on our claim if we have another, if we have an encounter to bill that with. Otherwise, these are still going to go on our cost report. We get our reimbursement off of our cost report. That's what that's going to look like. Let's look at multiple encounters. Multiple encounters are allowed on the same day. And we actually work backwards into this definition. So basically encounters with more than one FQHC practitioner on the same day, or multiple encounters, blah, 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 is one visit, except what actually happens are the exception. Patient is treated in the morning, suffers a subsequent illness or injury, 2 visits. Patient has a behavioral health and a medical visit, 2 visits. The patient has a welcome to Medicare. Welcome to Medicare only is the only one that gets treated this way. Oh, excuse me. I'm sorry. I always get FQHC and RHC confused. For welcome to Medicare, we don't have a separately billable visit for IPPE. RHCs do, FQHCs do not. So here's what happens when we have multiple G codes. We report them all on the same day. And Medicare adjudicates these claims in a particular order. So we're going to report multiple G payment codes. The total payment amount will be determined by comparing the sum of charges for all of the G codes reported to the PPS rate. And so here's the order that we adjudicate these claims in. And here's the detail of what that would look like. So we're just going to report, just like we would the individual claims, we're going to report both of these. So I think this is a fairly common scenario where we have a new patient or an established patient, and we also have a behavioral health visit on the same day. So we had a psychiatric evaluation for anxiety and depression, as well as COPD and hypertension. Of course, that was clinical. We're going to consider these separately, and Medicare is going to adjudicate each of these line items, even though I think that may contradict the previous guidance. Modifier 59 is used to report unrelated services. And so modifier 59 is really what we use to report that subsequent injury. So this is a particular use for us as FQHC. So this is if the patient comes in the morning, they suffer a subsequent illness or injury. We use the modifier 59 on the subsequent injury. And this is what that claim would look like. Again, we're going to adjudicate each of these claims separately. Whoops. So 2 qualifying clinic visits, the total clinic payment gets to be $300 for that particular scenario. All right, everybody worn out yet? Let's talk about care management services. So we had some rolling changes to care management services. I used to kind of talk about those, but it doesn't do us any good anymore. So in effect, we have G0511 and G0512, which are RHC, FQHC specific codes. Our payment for these is set at the national average. The national average, this is an aggregate code. So we have 99490, 487, 484 that go into the calculation for what we get paid. So we get paid the national average of those codes. We do not report those codes individually. We get these 2 separate codes. Now we actually get principal care management is going to be included in here as well. So G0511, G0512, these are RHC, FQHC specific codes that no one else in the rest of the world will use, and we will not use the specific fee-for-service HCPCS codes to report these services. Now, we covered these pretty extensively in our other behavioral health, so I'm not going to go through these in depth, other than to say these can be billed alone or with another service. It can only be billed once per month. It's the national average of these codes, and actually now we've added a couple more to them. And the current payment rate for 2020 is $66.77, and coinsurance absolutely applies. So remember, we've got two different options for patient eligibility. We have multiple chronic conditions. Now we have one chronic condition as well, expected to last at least 12 months or until the patient's death, and puts the patient at significant risk. Now, option B, remember, was any psychiatric condition being treated by the RHC that in the clinical judgment of our provider warrants behavioral health intervention. So we have 2 options for the G0511, and these are the option B service requirements for the behavioral health component. We have to have an initial assessment with validated rating scales, and we have to have a behavioral healthcare plan in relation to that individual psychiatric conditions. But remember, we can use G0511 for psychiatric conditions. Now we have principal care management is added to that. So don't use G2064, don't use G2065, but those descriptions are now included in our G0511. So our aggregate payment is now going forward going to be based on these 5 codes. And we have principal care management. We can bill G0511. We have to have our initiating visit, and it's that 20 minutes of care coordination by a clinical professional. We have our billing providers, which are different from the people that can render the service. Consent is a really important component of our care management services. We have to make sure and document that we have notified the patient that we're going to provide, here's what these care management services are. There is cost sharing on these. And a lot of folks say, well, you know, people balk at the coinsurance. Well, all we have to say to the patient is, hey, what's your coinsurance when you get hospitalized? Our objective is to keep you out of the hospital. So there is cost sharing, but it's minimal relative to a hospitalization. No other practitioners, only one practitioner can do this and be paid for it during any given calendar month. The patient has the right to stop these services at any time, which will not have a detrimental effect on their care. And of course, they can consult with specialists outside of these services. We've probably had care management service requirements ad nauseum since they've come out. I'm not going to go over each of these, but the key is the comprehensive care plan. So we're going to have a comprehensive care plan. Our care management services are designed to actively address that comprehensive care plan and alter the plan according to the patient's progress. But the key, the reason we have care management is we have a comprehensive care plan, and that's what we're coordinating for the patient. We can bill once we meet the 20 minutes. Our service requirement is 20 minutes. It's not necessarily the end of the 30 days. So don't just get to the end of the 30 days and bill it. Bill it, and I misstate here, 99490. Bill it when you get to 20 minutes. That's the differential. We talked about the service B, the option B requirements in our last presentation. I'm not going to spend a lot of time on those. And we also talked about our G0512. Please make use of these. I think there's an enormous benefit that we don't capture enough. I'm going to back up here just for a second to our care management. Oh, I'm sorry. I'm not going to do that. Let's think about our care management services, though, in this context. All of the things that you can't bill as an FQHC because we're an FQHC. This is a perfect opportunity to use care management services to really supplement and fortify our service offering for our patients. I'm skipping through these slides because we covered this pretty intensively in our behavioral health component for care management services. But I really want to emphasize that these care management services where you don't have a service to see. So I have a standing call with a group of docs we're bringing up on our billing system in May. And they're suffering because their volume is off because of the pandemic. And they're also aggravated because so many of the phone calls that they provide, they're just on the phone all day, on the phone. All of those phone activities count towards care management. So here's the takeaway. You're providing care management services. You're just not formalizing and billing for it. So this is an opportunity to really bill for those care management services. Yes, copay and deductible applied. No, we're not going to bill the fee-for-service codes. We only bill G0511 or 512. Here's the deal. Now, there's a document out there that says something to this effect. But after our care management session last time, I got a question about, hey, what about our Medicare Advantage plans that just will not pay G0511 or 512? So here's a general rule of thumb, and this goes really towards our telehealth benefits as well. If the Medicare Advantage plan and you're contracted with them and they are paying FQHC PPS rate, bill care management services to them using G0511 or 512. Bill them as FQHC. If your Medicare Advantage plan is not paying your PPS and they won't pay a PPS and they insist they're just going to pay you fee for service, bill all of your services just as regular to them. Your contract is preventing you from being paid as an FQHC with them. So they're not going to recognize your FQHC status. So at that point, we're just going to bill fee for service to them, including those care management codes. So where I said don't bill a 99490, a Medicare Advantage plan that doesn't recognize our FQHC status, we just bill them like a fee-for-service Medicare operation would. That's the best way to think about it. And that includes for telehealth. Let's talk about virtual communication services. This is for electronic communication that is not a visit and does not lead to a visit. Remember, we have telehealth now, so we have telephone calls that can be encounters, but virtual communication is also for text and phone calls and email. So virtual communication service initiated by the patient, RHC practitioner can respond by telephone, audio, video, text, or email, and the time spent doing that counts towards your 20 minutes per patient per month. not just a telephone call, but all of these other communication mechanisms to take advantage of. Now we have 2064 and 2065, which are our principal care management services. All of these get billed under, and you know what, excuse me, I put the principal care management under virtual communication. I should not have done that. So scratch that under virtual communication. The G0071, those go under care management. Pardon me for that. But G0071 is our national average for all of the services that go into our virtual communication services, including virtual check-in as part of our virtual communication service, includes remote evaluation as part of our virtual communication services. It does not include remote patient monitoring. We don't have a benefit for remote patient monitoring. Not for us. We don't get it. Check-in, yes. Evaluation, yes. Monitoring, no. Easy way to look at it. Right now, it's $24.75 because we have some services included in here during the PHE that are probably going to go away. But for right now, $24.75 is our payment for 2021. Telehealth and virtual communication services are not the same. Our RHC and FQHC practitioners are billable, but it's any of our clinical activity performed by nurses and other personnel, clinical personnel, that count towards our 20 minutes. Part of our same with care management, we have a coinsurance and deductible. Coinsurance is 20% of whatever we charge. Oh, I got my data service off there. We just bill the virtual communication service as its own line item. Since it cannot result in an encounter, I did not give an example of billing this alongside an encounter. All right, we've sped through a lot of material. I'm going to wrap up here with telehealth. So pre-COVID, we could not be a distant site. We're statutorily excluded from the patient being in the FQHC and our provider being at a distant site. The distant site is where the provider is. The originating site is where the patient is. The originating site could not be the patient's home, and the distant site could not be the FQHC. Previously, that 780 and Q3014, and we still may have an instance, but this is just for originating site only. This is not for telehealth encounters. This is for putting the patient in front of a camera at our FQHC. For the public health emergency, we are able to bill our telehealth visits using G2025. Right now, this has been extended through January 23rd, 2021. I would certainly expect another extension of that. When the public health emergency ends, right now, there has been nothing to extend telehealth benefits beyond the public health emergency. So our FQHC as distant site, our FQHC, our patient home as originating site will all go away absent other legislation. There's been nothing to change that. RHC FQHC will not be able to function as the distant site. So our providers at the FQHC, and we're seeing a patient, the patient's at their home, and we have a telehealth visit, that will go away. Telephone only visits will revert to virtual check-in services. That's an originating site claim example, fairly boring, gets us $23, right? But if we bill as a distant site, our G2025 payment, we get the $92.03. So this is an E&M, so I don't want to go too far down this rabbit hole, but there's our telephone only visits during the PHE. After the PHE, expect telephone only to go back to G0071. I can't imagine, even if we get a telehealth benefit changed, that universally we'll be able to keep telephone only visits as encounters. That's the piece that will change back. CS modifier is for COVID related services. Modifier 95 is not required, but is recommended. So you can track these services and you're going to pay $92.03. Don't have a big charge on that. Just charge the $92.03 and keep it at that. The big thing is we have to notify the patient that they're being seen via telehealth. Whew, hey, I made it in an hour. I can't believe it. So honestly, I had many more references than these. Really, a big part of them on care management services, on some of this other guidance for the public health emergency. But these are our Bible. If you really want to drill down on how to report these codes, look at the claim processing manual, not the Medicare benefit policy manual. The Medicare claim processing manual really gives us the detail on what these claims should look like. So that's what I've got for you today. I'd be happy to entertain some questions. And as we mentioned at the top of the presentation, this is a recording. This is my contact information. Please don't hesitate to contact me and ask questions. You know, honestly, a lot of the questions that I get on this material are pretty complicated questions. And sometimes it takes me a little bit to respond. So I will respond to your emails and your questions. If you haven't heard from me, never hesitate to say, hey, ding, ding, I'm still here. But normally I'm trying to vet my response. So I'd love to listen to any questions that we've got. And if you don't have any questions, let's see, cost sharing should also be able to be reduced according to the slide if the patient is qualified. Yes, I totally agree with that. And the problem we get into is we can really even do that as RHCs, but the issue becomes, how do we not discriminate against some of our other patients? But yes, on the face of it, absolutely. Cost sharing can absolutely be applied to our site and should be applied to our sliding fee scale. Now, of course, the big problem with our sliding fee scale is it just doesn't get utilized as much as we would like it to, because people don't want to come claim their poverty, right? I wouldn't want to. But yes, that's exactly right. Cost sharing applies to sliding fee scale discounts as well. So I'm not seeing a bunch of other questions out there. And yes, too many people assume sliding scale is only for uninsured patients. That is a really good point. It is for everybody, but we do have sometimes difficulty applying that universally. But yes, that is a really, really good point. Too many people assume that sliding fee scales are only for uninsured patients. They're for all of our patients. But to use the sliding fee scale, keep in mind we're going to get audited on that, and HRSA is going to want to see some of your income verifications that you've given patients. So thank you. Not sure who that was. Abraham, but thank you. So I see Carolyn trying to join in here. Carolyn, I think you're muted.
All right, are you able to hear me now?
There we go. There she is.
Got that fixed. All right. Well, Mr. Charles James, we do really appreciate your presentation today. I don't see any questions in the Q&A for us. So I believe that
baffled everybody.
topic greatly. Thank you, and everybody have a great day.
Thanks for having me. Thanks a lot, folks. Bye-bye.
Bye.